Welcome to Geriatric Balance and Fall Prevention. Thank you very much for signing up for this program. We're going to move quickly through some examination tools that are resources you can easily download and print out copies of from online. And I'll provide those resources to you. And then we're going to look at some of the evidence that surrounds some of the interventions that we're using to promote balance and to prevent falls. So this is a program primarily showing you what intervention tools to look at that are represented by the literature, and also showing you a selection of examinations and functional outcome measures you can use to show an improvement in balance for your patients for your documentation, particularly for insurance and Medicare purposes. Welcome. My name is Teresa Schmidt, and it's a pleasure to be able to share this with you today. Now, in some of the examination tools, I will be going through them rather quickly. You can feel free to print out the slides that have the tools on them, as well as download the tools in easily documentable format from some free resources you'll see online. So here we go. If you're using this program for home study and you wanted to apply to get continuing education credits, please visit my website, edusize.com, online, and you can see information about filling out a post-course seminar evaluation form, as well as taking a post-course examination, a multiple choice format. And if you complete that with a 70 grade or better, you can get a continuing education certificate. Edusize Resources Incorporated, my company, is approved by many boards for continuing ed credits, but we are not approved by all boards. So do check with your own state board or check us through our website for more information. Thank you very much. Now, I mentioned there are some functional outcome measures we'll be covering today, and most of these are copyrighted, which means we cannot put them in the program and give them to you directly. However, I'd recommend that before you start the program, you go to the website you see here at the bottom of this slide, www.rehabmeasures.org. They're a fabulous rehabilitation outcome database that is free for practitioners to look at, and it gives you the outcome tool as well as some great information on the latest research that's done looking at minimal detectable change, minimally clinically important difference, and other statistics that may be of interest to you. In some cases, it does also give normative reference values, and you'll see that reflected throughout this program. So go ahead and check out some of these tools at rehabmeasures.org. My name is Teresa Schmidt, and my background is I'm a physical therapist, board certified in orthopedic physical therapy. I've been a physical therapist for 30 years. I'm also a licensed massage therapist, and I've worked in a variety of different clinical practices as well as academic practices, and I'll share some of that clinical experience with you as we go through this program. Should you have questions that arise, feel free to contact me or send your questions through my website, which is at the bottom of this slide, edusize.com. Who hasn't seen the commercial, "I've fallen down and I can't get up"? That's a problem. One of the issues I like to train my patients in is to make sure they know that if they got down and weren't hurt badly, that they find a way to get themselves back up. So I actually do practice some of that very aspect of how do you respond to a fall. And falling's part of life. Now, if you're little and you're falling, you're having a good time, you're pretty close to the floor, you got that low center of gravity, not so likely to be injured. But as the aging process carries on, our bodies are not likely to withstand the impact to the same degree, and there's a greater level of morbidity and mortality. So we want to make sure, can we prevent some of those falls from happening? To do so, we need to have adequate balance. What is the balance? It's basically the ability to maintain our center of gravity over our base of support. And you'll see those terms listed throughout here. C of G, or COG, center of gravity. Our center of gravity, if we're standing, is typically around our lower pelvis or second sacral segment. The base of support is the support base. Where are our feet contacting the floor? Are they close together or far apart? Or sometimes people are in quadruped. There might be 4 points of contact, so a very wide base of support, or BOS. So balance is essentially a state of equilibrium. And this is a quote from Guccione, in that adequate postural control requires keeping that center of gravity over a base of support during both static and dynamic situations. I remember early on when I was in PT school, we did mostly static balance testing and training. But that doesn't necessarily carry over into functional activities of daily living. You need to also have a moving or dynamic balance training program. The body must be able to respond to translations of the center of gravity. Okay, voluntarily imposed in intentional movement, something I'd like to do, or involuntarily or unexpectedly imposed, such as slipping or tripping. So are we ready to be tipped out of balance, or are we planning to move ourselves out of balance? And here's a perfect example. This is called Balance Rock in Garden of the Gods, Colorado. An interesting spot. There's actually space under that rock for a human body to stand. Would you be standing in that space, trusting balance? Balance is maintained by postural reflexes. So our center of gravity is basically stabilized to allow for changes in posture and movement in response to an outside force or possibly something volitional. You'd like to make a change, a displacement of your center of gravity. There are automatic postural reflexes or responses that attempt to make corrections when your center is moved away from your base of support. And there are three systems in balance physiology. You have your sensory system, your proprioceptors, your central processing system, of course your brain, central nervous system, and the effectors, the muscles that make these reactions occur. Let's take a look at each of these in turn. Sensory. Proprioceptors detect the relative joint position and movement of the body in space and respond not only to the changes in position relative to the earth, but changes in trajectory, direction, speed. How about your central processing system, your brain? Okay, it takes in all these afferent impulses from your sensory systems and then puts them together to respond to a perturbation or a push away from your center of gravity over your base of support. Then, of course, your muscles, your effectors, they're the ones that are going to make the responses happen. You could develop problems in any of these systems. So let's look at the sensory system first. You have somatosensory, vestibular, and visual. In this course, we're looking primarily at the somatosensory system and visual and how we can utilize rehabilitation to improve the work of these systems. There are courses in vestibular rehabilitation, but they're much more lengthy than what we're covering today, so I do recommend that you check out some of those online. All three of these put inputs into the brain, into our central processing to give us information on position and then allowing our brain to choose how to respond to a change in that position. What is in that somatosensory system? Your proprioceptors, your sense of movement from your joints, your ligaments, your tendons, your muscles, looking at not only the speed of your movement, but the changes in length of those ligaments and muscles. Now, as you know, when we get older, strength and flexibility are reduced, so that somatosensory system ages, and those changes can be deleterious to balance. Our perception of where we're moving in space, our perception of position, could be altered by problems as we age, like peripheral neuropathy, not picking up the sensations properly from the joints, maybe diabetic neuropathy. What if there's a biomechanical fall? How many people as they age have altered alignment in their feet or ankles? That's our first defense, moving our center of gravity away from our base of support. If there's not good alignment there for the proprioceptors to respond appropriately, well, of course, we could have a challenge to balance. Vestibular system, our auditory nerve, our vestibular system from our inner ears, is composed of a vestibular labyrinth. Your inner ear senses motion of your head, and it comes from two sources. Your semicircular canals, which are the three fluid-filled structures, okay, that sense what direction are you moving, and also the velocity of motion, particularly rotary motion. Fluid moves throughout these canals, and the direction of your motion moves the fluid. The speed of your motion also is interpreted by these semicircular canals. Inside, you have otoliths. Yes, you do have rocks in your head. They're called otoliths, utricle and saccule. These detect straight line motion, linear acceleration, and also as your head moves, those rocks inside your head, the otoconia or otoliths, actually move around. And as they get tossed around, they land in a different perspective inside your head. And those stones move over these tiny hair cells lining the inner ear. Those cells respond and give information as to where those otoliths are moving. Sometimes the hair cells are damaged. Sometimes those rocks get stuck. And then people have vestibular problems detecting where they're moving in space. Vestibular disorders are pretty easy to pick up when you're doing your intake with your patient, doing your interview. And then, of course, the specific testing which we're not covering here in today's seminar. But just to give you the overhead. If someone's complaining about dizziness, lightheadedness, feeling disoriented, they have a sense of spinning, we call that vertigo. Okay, they might have a sense that they're floating. It might even make them nauseous or cause them to have blurry vision. Sometimes they'll say, well, I feel like I'm falling. That's telling you that it could probably be a vestibular involvement. You could have peripheral vestibular problems in the labyrinth, central vestibular problems, maybe a stroke affecting the vestibular nuclei in the brain, systemic problems in the body, or circulatory problems could also affect the vestibular system. Some common vestibular diagnoses, and these are a mouthful. Typically, patients can't even pronounce them when they come in. The doctor said it had something with V's in it. And V's, I'm thinking vestibular, benign paroxysmal positional vertigo. There's a mouthful. Who came up with that one, right? Specific head motions. If I turn my head just a certain way, I get dizzy. But if I turn my head a different way, it doesn't seem to bother me. And it apparently comes out of nowhere. They don't really know where people get this BPPV. When I listen carefully to patients, though, I'll often hear that there's a history of some kind of head injury, inner ear infection, or something else that you think, gee, that might have contributed to it. Meniere's disease is an inner ear fluid imbalance, and people will say, yeah, I got that ringing in my ear, the tinnitus. They might have hearing loss. I feel full in my ears. Okay, again, no known cause. Perilymph fistulas, and this is when you have fluid leakage. That fluid that houses inside the inner ear is leaking from the inner to the middle ear. And that again could be due to injury or infection. Vestibular neuritis, most typically an infection causing inflammation of the vestibular nerve, and labyrinthitis, which is very common, ear infection. Let's look at the sensory system from the visual perspective. What changes as we age? Depth perception. Can we see things in 3 dimensions? As we age, our depth perception tends to fall off. So someone looks to see the edge of a chair or the edge of a step. Oh, I fell down the stairs, because they couldn't appreciate the depth. The visual sharpness or acuity also tends to decline. And when was the last time they had their eyes examined and their glasses updated, right? Some of these folks I see in my office haven't changed their glasses in 10 years and haven't had an eye exam in 10 years. And they're wondering they can't see where they're going, and that's why they fell and broke a hip. So these things need to be taken care of. Contrast sensitivity. This is something that declines measurably with age. And what is contrast sensitivity? I'll give you an example. I went to the pink lady's house. I don't usually do home care. I have a private practice, but occasionally if it's a long-term patient, somebody I know for a long time, I'll stop by the house. Yeah, I know you broke your hip, you just had hip pinning. Let's see how you're doing there. So I go in, I walk into this lady's house, and what does she have? Living room's pink. The walls are pink. The floor is pink. Guess what color the chairs are? Pink. Couch, pink roses. So if she's going to move with her walker across her living room and look for the chair, that pink chair seat just blends so well with the pink rug, she can't see the difference between the chair and the rug. And then she goes to sit, she falls short of the seat. Oop, right on her tuchus. So that's a problem. Contrast sensitivity. What's the answer? She's going to change her furniture? Of course not. But can she get something like a black napkin, a black towel, something with a high color contrast? I want you to put a black towel on your chair seat so that when you go to sit, you can see the edge of the chair. Looks different than the floor. Problem solved, and inexpensively. So it's important. Think about if you're looking at a staircase. Maybe the stairs are made out of wood. Lighting might not be very good. So one brown stair on top of another brown stair. Can you see the edge when they're all the same color? Not if you're older. So what do? Go to the hardware store, get some of that bright yellow neon tape, and put tape on the edge of each step. Or paint the edge of each step. Something that makes a contrast and easy to see. It can make a huge difference in your client falling down the stairs or not. They also don't have very good peripheral vision, which is your lateral vision. If you're looking forward, how do you see things coming from the side? Your brain is naturally tuned into seeing lots of movement in the peripherally. But if you don't have good peripheral vision, one of my patients is walking across the parking lot with her shopping cart. Not good peripheral vision, what happened? Shopping cart came flying with the wind across the lot, knocked her down. She also has poor what? Poor hearing. So she didn't hear the shopping cart coming at her. She didn't see it with the peripheral vision. She's seeing straight ahead, knocked her over. So if you can teach people look around a little bit more, be aware. You don't hear well, get the hearing aid. Okay, very important. Central processing, what's happening in the brain. As we age, how many people are having TIAs, having strokes, having problems with dementia? Central processing, the brain is not working as well. It has to process the input from all of these other systems. If there's a problem, you're going to be missing some of that automatic postural response. Now, a guy named Nashner came up with what he called a postural response model. And our reaction to outside perturbations of our center of gravity uses three mechanisms, or three strategies to manage our posture. Ankle strategy, hip strategy, and stepping strategy. So guess what? If it's safe for you to practice with this and you don't have significant balance problems, you have something to hold on to or a person to work with, try out some of these strategies so you can feel them right there on yourself. So stand up. Now that you're on your feet, okay, make sure there's nothing for you to bump into. We're going to check out your ankle strategy. So stand up. If you have really good balance, put your feet together, touching. If your balance not so good, leave them a little bit apart. And make sure there's a chair behind you in case you do fall back. Okay, so caution first. As you're leaning back, standing up, leaning back slightly with your shoulders. And as you lean back more and lean back more, what happens? What do you feel in your feet? I'm leaning back, and what do I feel in my ankles? You feel your ankle strategy. Your ankles are the first line of defense in correcting your displacement over your base of support. Okay, so corrective motion here, if you have a small change, a small perturbation of your center of gravity, is going to come first from the ankles. If your ankle muscles are weak or they're stiff, they're not going to work so well. Okay, stand up straight. Now, standing up straight and just lean forward. Let your head lean forward, chest lean forward, lean forward. What do you feel down in your feet? You feel the pressure in your toes. What do you feel? You feel your gastroc muscles, your soleus muscles kicking in to keep you from falling flat on your face. That's your ankle strategy. So what's the sequence here? The normal sequence for your ankle strategy is your leg muscles, lower extremity, LE, muscles recruited from distal to proximal. Ankles, muscles recruited first, followed then by your knees and your hips and so on. So what's going to fire first? You're falling backwards, your tibialis anterior, your dorsiflex is going to fire to help you pull back forwards first, then your quads. Okay, if you're falling forward, your gastroc's going to fire first, then your hamstrings, then your glutes. So there's an activation sequence. Okay, now if you have a bigger perturbation of your center of gravity, your hip strategy is going to kick in. So this is, again, looking at anterior, posterior, or AP directions. Your hip strategy, the corrective motion occurs primarily about your hips. Your upper body stays more rigid. So standing tall, lean your trunk forward a lot. And if you lean forward a lot, what happens? Not only do your toes press down into the floor and you plantar flex your feet, but what happens? The glutes are kicking in. What if you start leaning backward? Your tibialis anterior, dorsiflexes are kicking in, but what's really kicking in? Those hip flexors are kicking in, trying to bring you back to the upright position. So there is a proximal to distal activation of the leg muscles using a hip strategy if there's a greater displacement of the center of gravity. And if you're doing some perturbation testing, pushing and pulling your patient to see how easily they fall over, in response to small pushes or perturbations, you should see their ankles respond first. In response to larger pushes or perturbations, you should see their hips respond first. So large perturbations, a proximal to distal activation of the muscles, and of course the opposite with a small perturbation. That's normal. Now what happens if you have a really big push? Okay, so if the center of gravity is taken way over the base of support, the patient will start stumbling or stepping. What do? You step. You take multiple steps to avoid falling down. So these are their typical balance strategies. Other strategies, taking lots of extra lateral steps, especially if you're being pushed sideways. And then what's really obvious, somebody with a balance problem, you see them walking, moving, the arms are swinging, the trunk's going, they're reaching for things. So these are things that you notice on patients. And the timing and the pattern of the response will vary a little bit between individuals. Here's the deal with older people. There's a higher incidence of antagonist muscle co-contraction. What does that mean? Well, if I'm falling forward and my gastroc's supposed to be kicking in, but my dorsiflexors, my tib anterior is kicking in at the same time, I'm not getting the right response to bring me back to upright position. That's confused. there's also more of a proximal to distal activation as we age, meaning the ankles are slowed down. The hips are kicking in early. So if the ankles are our first balance strategy, our first line of defense, and they're slowed down because they're not activated till later, there's a greater chance they're going to fall. And that's one of the reasons that people have problems with greater fall incidence as they age. There's timing delays too. Here's an interesting quote. See if you could figure this out. Sudensky and colleagues reported evidence of delayed latency in older fallers when compared with age-matched non-fallers. And they went on to say that the latencies, these timings that you could measure with electromyograms, latencies of the muscles, are not only delayed in the healthy older adult, but are even further delayed in the older person with a history of unexplained falls. Now, does that make sense to you? Yeah, sometimes you read this stuff in the literature, it doesn't make sense at all. History of unexplained falls, well, if they have a delayed latency, what do you think? That might just explain the fact that they're falling more for an age-matched cohort. Interesting stuff. So care when reading the literature. How about our effectors, musculoskeletal system? Muscles, joints, alignment, posture. How many of your older folks are in perfect posture? Now, how many of them are getting ahead of themselves over time? Kyphosis, forward head, rounded shoulders. That's a problem. It's putting the center of gravity away from the base of support. With the forward head posture, the kyphosis, they're more likely to be falling forward because that's where their center of mass is moving. How's the range of motion in some of your geriatric patients? Things are getting a little stiff. How about that ankle strategy? If they're supposed to be using their dorsiflexors to keep from falling backward, and the dorsiflexors are not only slow to kick in, but they don't have any dorsiflexion because their heel cords are too tight, what's going to happen? They're going to fall. They're going to fall right flat back. So this is something you need to look at. Range of motion is very significant. What's the strength like? Tested your geriatric patients lately? Can they easily get up and down on their toes? Can they do those heel rises? Not too well. So gastric soleus is weak. It's going to be tough for them to prevent themselves from falling flat forward on their face using their ankle strategy. So these are our reasons for looking specifically at strengthening and improving flexibility of those ankles, especially, and as well as the hips and knees. How many of you test endurance? How about the 6-minute walk test, 6MWT? How many steps can they walk? How many feet can they walk, or meters, in 6 minutes? Oh, that's a little too long, don't have that much time, patient's too tired? Try the 2-minute walk test. So measure the distance they could cover in a period of time. These are nice functional outcome measures. Well, McCagney showed that there is a correlation between balance and range of motion scores, anywhere from 0.29 to 0.63. The TNEDI, which is a balance test we'll look at later, performance-oriented medical assessment, TNEDI, correlates quite highly with active assistive range of motion of 0.63. So we got a long way to go. Let's look at some of the aspects of aging. Our population, okay? Average life expectancy, what is it today? Well, you generally don't get research statistics that are right up to date, so what do we have here? Average increase from 50 years at the beginning of the 19th century to 74 years in 1980, and in 2010, people typically live to be 78 years old. Okay? They say 2011, the American average life expectancy, 78.7 years, so it's growing. How long are you going to last? Right? So problem of falling. As we age, we tend to fall more frequently, and they're a bit more dramatic than when we're younger. So let's take a look at what happens as we age and how that increases the problems associated with falling. What's the impact of falls? Very high mortality and morbidity rates, okay? And people are growing older and older. Our volume of geriatric population is growing worldwide. And what are we going to do to manage the cost? Think about the Medicare costs of covering all these folks. And it's probably 1 out of 3 of them in nursing home will fall this year. So it's going to get expensive. So 1/3 of adults over 55 fall every year. And here's the main statistic. Remember this because there might be an exam later. Falls are the most common cause of hospital admission and injury death in adults over 65. Bing, there's your answer. Okay? Falls cause the most fractures in adults over 65, and 90% of those hip fractures are due to a fall. Needless to say, women have double the risk of men. How about in the nursing homes? Okay? 2003, 1.5 million people over 65 in nursing homes. It's expected to be 3 million by 2030. That's huge. So I'm investing in skilled nursing facilities. So nursing home residents account for about 20% of deaths from falls. Okay? 100 to 200 falls reported for every 100 bed nursing homes. Half to 75% of these residents are falling every year. Residents experience about 2.6 falls per year. That's a lot of falling down. Okay? In the emergency rooms in 2010, 2.3 million non-fatal falls were seen. A whole horde of them were hospitalized. And what did it cost medically in 2010? $30 billion. Amplify that in the next few years. Why do we fall more as we age? Well, we talked about some of the sensory systems. Bohannon, of course, showed that balance indeed does decline with age. They looked at people standing on one leg, standing on two legs, eyes open, eyes closed, typical testing. And they said, yes, the ability to stand on one leg decreases with age across the board. What else changes? How about the vision? We mentioned the vision. How about hearing? Hearing loss, presbycusis. We don't hear as well. Presbyopia, loss of vision. We talked about the contrast sensitivity. Patients can't see the edge of the chair they're about to sit in. They can't see the edge of the curb or step because it's all the same color. And they don't see those changes. So use those bright color contrasts. Okay? Highlight the edges of things, especially if there's going to be changes in level. You need to highlight that with contrasting colors. Think back to the pink lady. The first day I went into her house to check her out with her hip. Well, her house happened to have a southern exposure with the sun coming into the living room. So I walk in the door and it's bright pink, lit up in the sunshine, and I notice she likes to sit on the couch, which is across from the window where the sun is blaring in. So she comes forward from the kitchen in the back, walks out of a dark kitchen into this glaring sunshine in the living room. How does she adapt? Now she can't see because she's blinded by the light. And older folks, the eyes don't respond as quickly. It's like having flash bulbs set out. So I told her, look, you can't have this glare coming at you from a dark room to a light room. That's why you bumped into your cocktail table and skinned your lower leg. Thank heavens you didn't fall. Pull the blinds. When the sun is very high during the day and it's in your eyes, you need to pull the blinds so you don't have too much glare or an extreme change in lighting. How about when she steps outside? Get your sunglasses on. How about when she's in the kitchen where it's dark? She's going to be cutting up some carrots. Well, better have some good lighting in there so she doesn't chop off a finger. So very important to manage the visual defects as we age. Musculoskeletal, obviously, joint and muscle stiffness, myofascial stiffness. Weakness. Here's another great exam question. Quote, muscle weakness and walking or gait problems are the most common causes of falls. So we ask you later, what's the most common causes of falls among nursing home residents? What are you going to say? Exactly what you are an expert in. Muscle weakness interventions and gait disorders. These are things that we can manage. So we are the experts in this area. Let's look at how can we measure it and what can we do about it. So risk factors of aging, neurological system. Everything's going downhill. Less reflex sensitivity. Reduced proprioception. Nervous system slows down. Not as sensitive. The reactions are slower. Okay. More postural sway. Ever watch someone who's elderly try to stand in one place? They're tending to move quite a bit. And less sensation. The vestibular sensation is reduced as well. The brain's ability to plan movements, motor planning, okay, that's in a deficit as well. And there's reduced perceptual cues from the environment. Motor unit recruitment patterns altered. We mentioned that the normal activation is from distal to proximal. Well, when we're older, it goes from proximal to distal. The longer, farther away from your head, down in the ankles, responding more slowly. Motion is just not so coordinated anymore. That dance just does not look the same. And of course, how's the memory? How's the cognition? How many folks are suffering from dementia or cognitive impairment, psychological confusion? Think about all the drugs people are on, how confusing that could be. And all this combined, they know things are changing, so they get fearful of falling. And that's called tophobia. There's actually a name for that, fear of falling. So how about the heart and blood system? Dizziness, they could have orthostatic hypertension. Changing position, the blood pressure goes down. Less oxygen to the brain. They get dizzy, they could fall down. Vertebral artery compromise, how many people have hardening of the arteries? Less blood flow to the brain. Okay, so if you hear about people falling over and over again, repeated fallers, think about having them checked for cardiovascular or neuromuscular compromises. What about all the folks that have peripheral neuropathy? So decreased sensation, especially in the feet, very often due to diabetes or poor circulation. So they can't feel the way their feet are moving on level surfaces. They're going to be more likely to fall. Now, one of the things Medicare required us to start doing in 2013 is you have to make a list of all the medications and all the different substances patients are on. You ever see this laundry list? It's called polypharmacy. Some patients are on 20 different drugs. Does anyone have an idea of how they interact? Not a clue. But we do have some very good studies telling us about specific medications and how they affect the elderly. So they increase the risk and rate of falls and fall-related injuries. That is a fact. It's been documented in numerous studies, especially drugs affecting the central nervous system. Sedatives, anti-anxiety drugs, okay? And here's a little tidbit I learned actually just preparing this seminar. Fall risk is significantly elevated during the 3 days following a change in these types of medications. So I like to tell patients, you know, if you ever change your medications, check with your doctor and be extra careful, because in the couple days after that change, you might be more likely to fall, so be extra careful. Education is key. So what happens as we age? Kidneys don't work as well, liver doesn't work as well, so it is not processing the drugs and excreting the toxins efficiently. Drugs stay in the system longer, and we really don't know how they interact. Leipzig did a meta-analysis looking at the relationship between falls and drugs use. Okay, significant risk of falls in people with psychotropic drugs, antiarrhythmics, diuretics, and digoxin. And if you don't know what kind of drugs these are, go to www.fda.gov, Food and Drug Administration, FDA. Get information on the latest about drugs and interactions. More on drugs that increase falls, antihypertensives. How many folks have high blood pressure, yet they're on drugs that increase their risk of falls? Diuretics, beta blockers, nitrates, okay? That'll give them the opposite. Maybe now they don't have high blood pressure, might be too low, especially with changes of position. Sedatives, barbiturates, narcotics, makes people sleepy, woozy, positive correlation to falls. Now, how about your patients with the Parkinson's disease? Well, gee, they gave them a drug to help their movement, yet some of those anti-Parkinson's drugs and some of those antidepressant drugs, particularly the tricyclics, will contribute to orthostatic hypotension as well. So on the one hand, maybe the muscles work a little better. On another hand, the circulation's not so good. Alcohol. Try mixing that with some of the drugs these people are taking and wonder why they're falling down. So tranquilizers, antipsychotics, the list goes on. Sedatives. You can have side effects of rigidity, bradykinesia, slowing some of the movements, making movement difficult. Obviously, narcotics that are knocking people out, muscle relaxants, the muscles are slow, benzodiazepines. And surprisingly, even non-steroidals like Motrin, naproxen, this kind of thing could make people dizzy. How about what's in the environment? We're so busy looking at the patient and trying to change something in them. What about the environment we're in? We talked about the pink lady. Well, I went to someone else's house just as a courtesy to see how they're doing after they had a fall and broke their shoulder. And what did I find? Loose rugs in the bathroom. And what's on the rug where you walk in the door? That long plastic runner. And what do the edges of that long 20-year-old plastic runner look like? Curly. So now they have a spot where the rug's flipped up that they could easily trip on. You have to get rid of these things. You absolutely have to get rid of these things. So take care for the slippery floors, the wet floors. Make sure they have some non-slip surfaces, good shoes, of course. What about the uneven surfaces? A threshold going from one room to another. Can you put a little ramp there? Can you highlight it? Maybe with some brightly colored tape so they see it. You ever see the shoes some of these people are wearing? Or how come they call those things slippers after all? Because you slip when you're wearing them. I like a closed shoe, a closed slipper with a rubber base, something that's not slippery, okay? So think about getting their footwear checked out, the lighting we talked about, the contrast. How about the patient comes in, yeah, I borrowed this cane from my next door neighbor. Well, honey, that's too high for you, or it's too low for you. Make sure they have properly fitted assistive devices, okay? What about in the toilet? What about in the bed? I had a lady who was so adorable. She's like, I got these great satin sheets. She's like 87, still wants to be sexy, right? God bless her. But she's got these satin sheets. What happens when she sits on the edge of the bed? Now, she's little. She sits on the edge of the bed. She just slides right off the bed because it's slippery. And the bed is high because, of course, she has to have the pillow top mattress. So these things could be dangerous. You need to educate patients. So, how about the flannel sheets? Yeah, maybe they're not as sexy as the silk sheets, but at least you won't slip off and land and break a hip. So look at things. Toilet height. How about grab bars in the bathroom? I've gone to patients' homes and they say, oh, we don't have money to put up grab bars. Well, how about that dancing pole? You ever see those poles used for pole dancing? They are telescoping. You can put them to the ceiling, to the floor. You don't even have to hire a handyman to install stuff through your tiles. So that can give them a good grab bar. There's so much online on assistive devices, and there's a lot of people out in the community that do community service for people to help modify their homes to make them safer. So check and see what's out there in the community for your patients. How about, yeah, I'm watching the grandkids this weekend. Yeah, my daughter-in-law is dumping them on me again for the 40th time. And what do you have? You have the little one's going to be crawling across the floor. Now you have a moving obstacle. How is she going to manage that? How is she going to get around that? Well, I told her a great idea. I said, if you're tired of watching the grandkids and you don't want them to be dropped off anymore, as the kid's moving across the floor, just step on it, trip, and then you won't have to watch them again because they don't want you stepping on your kids. No, not really. That's not a good recommendation. But it does work. Kids won't be dropped off again. So obstacles. Be very careful with the obstacles. How about medical risk factors? Cardiovascular problems, low blood oxygen, hypoxemia, dizziness, low blood volume. How many of these people are drinking enough? Okay, they tend to get dehydrated. Electrolyte imbalances. How many have problems with digestion and poor nutrition? Okay, that can contribute. Problems with their feet, neuromuscular disease. Maybe they have MS. Maybe they have Parkinson's. Central nervous system injury. Maybe they had a stroke, brain tumor. Okay, so lots of risk factors. Make sure these are properly medically managed and that you know exactly what they are. So what about the personal implications of falling? For a lot of people, it's embarrassing. Yeah, I fell and I broke my hip. Oh, I fell and I broke my wrist. Now she has RSD. Well, what happens? They landed in a nursing home for a short period of time. They're trying to get back home. They lost their independence, limited ability to do everyday activities. And so they're not as confident as they used to be. I had a patient who happened to live in a downstairs basement apartment, has to go down 10 concrete steps to get there. She'll barely go out anymore. She said, oh, I used to go to the senior center. I used to go out and have lunch with my friends. And now she's getting no exercise. She just sits at home. So she's gaining weight. She's atrophying. She's getting out of shape. She's afraid to go out since she fell. I'm going to fall again. How am I going to manage my way across the parking lot? So that fear of falling is huge. And it limits social interaction. And now she's getting depressed because she's not getting out. So what's the difference too? The lady I'm speaking of isn't really that old. And she's noticing her friends that are 10 years older than she is are in better shape. Everyone ages differently. Okay? Everyone has different resources. That lady I was mentioning is on Medicaid. She doesn't have a lot of resources financially to help her out of literally the hole she's in. What about people who have more resources? Might work out. Can you access resources in the community to help your patients? Over time, regardless of resources, people lose their adaptive capacity to compensate. And that's where we come in to try to improve their adaptive potential. With exercise, training, you'll see. So how about examining balance? What functional outcome measures are typically used today? Of course, you have your subjective interview. Not going to bore you with reading all the questions, but do your interview. Find out, what's different since you fell compared to before? How are your activities different? How have you changed your life as a result? But the key is objective measures. Look at their posture. Are they swaying or not? How many people are not standing tall, right? So look at them from the front, the side, and the back. What's typical? Postural changes, the forward head, the kyphosis, the hip and knee flexion, the excess anterior pelvic tilt. What can we do to help that posture? Balance examination tools. So you have your traditional old-fashioned tests, right? Stand with your arms together, the typical Romberg. Let me see you do that for 30 seconds with your eyes closed. Look at how the person sways. So feel free to try some of these tests, but be very careful to protect and guard the person that you're testing to make sure they don't fall down. So use appropriate guarding techniques. On the Romberg test, if they lose their balance or they open their eyes, to try to correct themselves or step to catch themselves, it's a positive Romberg test. Of course, they came along and changed this to a tandem or sharpened Romberg. I want you to stand heel to toe with one foot in front of the other. Okay, dominant leg is behind. Arms folded on the chest for 60 seconds with your eyes closed. And there's normative reference values for this, and I've given you some of these norms. I won't be reading through the norms here. You can print these slides out and take a look at them, but you do want to make your own normative reference value chart for use in your clinic. Grading the unilateral stance test. Okay, so stand on one leg. Now this is interesting. Try it in place if you're safe doing this. Just stand up, stand on one leg. If that was all I told you, what are you doing? Who stood on their right leg? Who stood on their left leg? Did I tell you where to put your hands? Did I tell you with your eyes open or closed? Did I tell you to bend your knee at 90 degrees and leave your hip in neutral? How many of you are standing with your foot in front of you? How many of you are standing with the foot behind? Here's the problem. Our so-called normative tests, all the therapists are performing them differently. That's a problem, because then they're not normative. You want to do the tests the same way, make sure everyone in your clinic is doing them the same way, and that's what we're pointing out here. Again, I'm not going to read every nuance of each slide and bore you to death, but I want you to take a look at that and make sure everyone's doing it the same way. So, ask the patient to cross their arms, lift their favored leg, meaning it's typically their dominant leg. Okay? If you tell them to bend their knee 90 degrees and lift their foot behind them, you're going to give them a Charlie horse in the hamstrings. If you try that on yourself, you'll see right away. Most people will lift, they'll flex their knee and hip a bit, and their foot will be just below their knee. So make sure they're comfortable. Have an average of 3 trials of standing on one foot, see how many seconds they can do this, and what's the result. If they can't stand on one foot for at least 5 seconds, okay, if the elevated foot hits the ground, the arms uncrossed, people go to reach, the stance leg moves, or the trunk tilts more than 45 degrees, they're done. There's a very high risk of falls if they can't stand on one foot for at least 5 seconds. So we call those our cutoffs. What's our cutoffs? 5 seconds here. Do we have averages or normative values? Yes, we do. So Bohannon has these across the decades from the 20s to 80 years old. I guess he didn't have any volunteers above the age of 80, but there you go. So make note of these norm values, eyes open versus eyes closed for standing on one leg. How do people feel about their ability to prevent themselves from falling? Falls efficacy scale. What's the psychological aspect of balance? Well, this is the scale right here on a scale of 0 to 10. If 1 means you're very confident and 10 you're not confident at all, how confident are you that you can perform the following activities without falling? And you'll see these on the next slide. A score of greater than 70 indicates that they have a fear of falling. If they have a fear of falling, what's the consequence of that? They're going to avoid doing stuff. They're going to avoid activities. You don't use it, you lose it. You're going to get out of shape, less interaction, and the whole cascade of negative events. So here I've given you the falls efficacy scale, and this is quoted from the scale. And feel free to, again, download these at rehabmeasures.org, and you can have your own scale to use with your patients. Easy everyday things like getting dressed, washed, moving around the house. How about another test that's typically not done in many situations? Vertebral artery syndrome. If a patient's saying they're getting dizzy, and you're asking them on their intake, well, when do you get dizzy? I get dizzy when I move my head around. Well, is it vestibular? Is it circulatory? How do you know? Well, vertebral artery syndrome test. And this test is performed by people who are licensed to do so, of course. So we check with the patient laying down. You don't want to do it with them sitting up, because if they fall, now you have to pick them up, okay, or catch them. Patient supine, you put them passively into neck rotation with extension and side bending to the same side. If they get that nystagmus of the eyes going back and forth, dizziness, one pupil dilates while the other constricts, okay? They get nauseous. Some people even vomit on the test. Okay, they need to see a physician. The vertebral artery is probably clogged, cutting off blood supply to the brain on the side to which you're testing. So get them out of that position and tell them to avoid moving their head into extension or side bending until they see the physician, which should be soon. Now, some people have shown in the literature that they have stroked out patients just doing the test. So unless you are qualified and educated to do the test under your State Practice Act, I would recommend tell them to see a neurologist. How about, are they getting dizzy because they're changing position? What about the position changes? Blood pressure. They say, massage therapist called me up recently and said, oh, I was working on an elderly patient with Parkinson's disease, and I did a great massage, and as soon as I got her up after the massage, she was all dizzy and falling over. What did I do wrong? I said, well, you got her up too quickly, and if she has Parkinson's disease, she's probably on medication that causes orthostatic hypotension. She's like, what's that? I said, well, during changes of position, when you first get up from a recumbent or sitting position, you lose some blood supply, blood flow to your brain, and the blood pressure has to pick up again. Okay, so if you have abnormally low blood pressure, changing position, got to get the oxygen back in your brain. So tell the patient to take some deep breaths. Okay, if they're getting very dizzy, you might want to lay them down and just get them up more gradually or more slowly. So ask the patient, do you get dizzy when you're changing positions? Probably orthostatic hypotension. Get the blood pressure cuff, measure their blood pressure when they're supine, get them up immediately into sitting, measure it again. Did it drop? Orthostatic hypotension, and also from sitting to standing. Of course, refer to a physician. They might need their meds changed. They might have other problems that need to be medically addressed. How about the functional reach test? How far can you reach when you're standing or sitting without falling down? A functional reach test in standing is a standard test. You're probably familiar with that already. When they're standing, they take their dominant arm, reach forward as far as they can, and of course, if you have them standing next to a wall, there's a tape measure, and they're reaching forward, shoulder flexed 90 degrees. Some people have an open fist, some people have a closed fist, but you measure from where they started, which might be 0 on the tape, how far, oh, they're able to go 11 inches. What if they can't reach with their hand because they have an elbow flexion contraction? You can measure from the acromion, tip of the shoulder. Where did they start? Say they could only reach with their elbow flexed. Where did that acromion end? So how far can they reach forward without the feet lifting up off the ground? Okay, so you're measuring the exertion of reach. Duncan and colleagues have shown that frail persons with reaches less than 6 inches have quadruple the likelihood of falling than people who can reach greater than 10 inches. So you could do this sitting or standing. It's recommended, again, use an average of the last 2 scores of 3 trials. Here's some of your means across the decades of functional reach. Isles did a lot of publication on these studies, so you're going to see that at the top. Other studies, I've given you some reference values that were in the literature. Notice they're not perfect. They don't all match. These are people, after all, that they're measuring. But these are the values that they've come up with. How about somebody who is not able to stand? Maybe they're wheelchair bound, so you did a modified functional reach test in sitting. So have them sitting with hips, knees, and ankles at 90 degrees, sitting against the chair back, feet on the floor. And they say do a trial with the uninvolved side near the wall, reaching forward, and one with sitting with the back to the wall, reaching to the right, one with reaching to the left. So using 3 trials, score the average of the last 2 trials. In other words, first trial is a test, just to get them familiar. And here's our means for sitting functional reach from Thompson and Medley. How about 5 times sit to stand test? Clock yourself. How fast can you get up and down out of your chair 5 times? So this is measuring more strength, okay? Patient sits with their arms across their chest in a standard chair. In other words, they're not pushing off from the chair or using their walker or cane. Arms across the chest, standard chair, again. Look through your clinic. Are all the chairs the same height? Probably not. So 43 centimeter height chair, 47.5 centimeter depth chair. Can they rise up and down, sitting to standing as quickly as possible? How many seconds did it take them to do that? Normal healthy adult, 8.2 seconds. Ready? Test it. Go. 1, 2, 3. Go ahead. Try it 5 times. How long did it take you? Here are some results. Number of seconds for 5 sit to stands. Some people call this the chair rise test. This slide is actually divided into 2 different studies. You'll see on the left in black and the right in purple. Whitney said in young controls from 23 to 57 years old, hey, it only took them 8.2 seconds. Young folks who were in for balance issues, almost double the time, 15.3. Older control, normal, healthy, 13.4. Older with balance issues, 16.4. On the right side of the slide, Bohannon came up with some norms, but he only did people in their 60s, 70s, and 80s. So how fast could they do the 5 times sit to stand? In their 60s, 11.4 seconds, 70s, 12.6 seconds, 80s, 12.7 seconds. Okay, so Whitney looked at this. Now, Whitney looked at a lot of different publications in the literature and has published extensively, so really, really good articles if you happen to see that name. They looked at the FTSST in 81 people with and without balance problems and said, you know, let's compare this to the dynamic gait index, which we'll discuss, and the activity balance confidence scales, and said, which identifies a percent of persons with balance deficits? 5 times sit to stand, 65%. That's pretty good for a quick thing that takes about 8 to 10 seconds to do. So you're in a hurry, you want to do a quick test, that's a good one. ABC test, 80%. Dynamic gait index, which is going to probably take you a good 15, 20 minutes to do, 78%. How about the step test? That little box, 7.5 centimeters high, little block. How many times can they step up with 1 foot completely on and off the block in 15 seconds? So here's your means for the step test. Again, different studies have come up with different averages. Isles, again, went across the decades. It's very handy. Hill and Brower did other studies, and they did just people in their 60s and 70s, so a little limited. Now, what if you have a patient, well, my patient can't stand up. They can't get up and down out of a chair. I'm visiting them in the ICU, and they're just bedside. So what do? The function in sitting test, or FIST. Now, here's another one that you could go online. I gave you in one of these slides coming up. SamuelMerritt.edu University has put together a whole video on this. Again, I'm here to give you resources. We're not doing every test. Go through the items, but if you want to see exactly how they're done, or you have a question about the nuances of how did you nudge them, where did you sit, they have a video online. So they're looking at 14 sitting activities that are functional in nature, and you can do this in under 10 minutes. This is great. If you're in acute care in a hospital, you're in the SNF, you're going bedside, you got to get in and get out of there. Simple things. You need a stopwatch, tape measure, a pen, a stool, and a chair. Easy. So put the patient on sitting on the edge of the bed, hands are in their lap, neutral hips relative to abduction, flex 90 degrees. Now, they're sitting with half their femur on the bed, not the whole femur. They're not sitting all the way back. Feet are flat on the floor or a stool. If the bed's high, they need a step stool. They explain the test to the patient as you would do with any of these. Informed consent. Here's what we're going to do. We're going to ask you to sit with the best posture you can. We're going to ask you to reach and scoot in different directions. I'm going to push on you. I want to see if you can manage not to fall down. Don't worry, I'll be here to grab you if you did lose your balance. And we want you to try these without using your hands. So for scoring, 0 points is they're fully dependent. They need physical assistance. 1 point, they need some physical assistance, and you document how much. So a score of 1 min A, 1 minimal assist, means they had 25% or less effort by the therapist. 1 moderate assist, mod A, 26 to 74%. Of course, maximum assist. If it took more than 75% of your effort to help them perform the task, it's a 1 max A. Score of 2. Well, they could do it, but they have to use one or both arms to assist themselves so they don't fall down. 3 points for, oh, you gave them verbal cues or gave them a little extra time to do it. Normal performance, but it's a little slow, or maybe you cued them a little bit. 4 points for independent. They could do it on their own. Here's your download, bottom of the screen, SamuelMerritt.edu/FIST. Download and get your training right there online. Okay, what's composed of the test? We have them sitting, and you nudge a little bit, pushing them on the sternum. Do they fall over? And it's a nudge. We're not whacking them off the end of the bed. It's a nudge. Posterior nudge between the scapular spines. Lateral nudge to the dominant side at the acromion. Can they just sit there for 30 seconds? Can they sit and shake? No. Left to right without falling down or using their hands. How about just sitting quietly with the eyes closed for 30 seconds? And it goes on. If you sit, can you just lift your dominant foot? So say I'm right-handed. Oh, I'm just going to lift my dominant foot. Can I do that lifting 1 inch twice? That's all. Not kicking, nothing involved. Okay, put something behind them like a pen. Sometimes I don't have a pen handy, tissue box. And you put it like a hand's width distance behind them. Can you reach that tissue box? See, can they reach back and grab it? Okay. How about, can they reach forward without falling? Can they reach sideways? So if they reach sideways, just to clear one ischial tuberosity without falling. Put the pen or the tissue box just between their feet in front of them. Can you pick up that pen for me? Okay. How about scooting? Scoot back in on the bed a little bit, 2 inches. Scoot forward on the bed, 2 inches. Can they do it without holding on, using one hand? How much assist? Go to the side. Move to your dominant side 2 inches. So you score all of this out of 56. Again, you could download the forms online. I've given you this to download the templates, and they also have web-based training. What's the minimal detectable change? Meaning, in the clinic, how many points shows that you have a minimal change? 5.63 points for acute stroke. Now, on this Rehab Measures website, you can see for a lot of different conditions, such as amputees, strokes, Parkinson's, spinal cord injury, they've listed minimal clinical difference, minimal detectable change, minimal clinically important difference. A lot of different variables are listed on the site. Okay, so that's for your bedridden patients. How about if they're walking, some gait exam tools? Who doesn't do the tug, right? Or the get up and go, the gug or the tug. Gug, the get up and go, okay? Patient moves from sitting to standing, okay? Get up and go from this chair. They're going to walk across the room to a wall, turn around, or a cone on the floor, whatever. Turn around, come back, sit down. And you take a look. Now the way they used to do it, just get up and go. You scored from 1 to 5. 1, you didn't think they had any risk of falling. 2, very slightly abnormal. 3, mildly abnormal. 4, moderately abnormal. What the heck is that? What's the difference between very slight and mild? Come on, this is ridiculous. And then they went to say there was a high correlation with falling if they had a 5. Well, somebody came along and said, that's ridiculous. Let's add an objective measure to this that makes sense. Let's time it. Okay, I'm going to clock you while you get up and go from this chair, walk to the wall, turn around, don't touch the wall, turn around, come back, sit down. So the tug, timed up and go. Easy. What do you need? A chair, a stopwatch. Okay. Here's some ranges of the tug means for community elderly, and it also gives you for some younger people as well, so from the 20s to 80. You'll see at the bottom the scores in parentheses are from other studies, so different studies give different amounts. How do you interpret this? In other words, what's the cutoff scores? Well, if it takes them more than 14 seconds to get up and go out of that chair, 3 meters or 10 feet away, come back and sit down again, more than 14 seconds, they have a high falls risk. If it took them more than 30 seconds, they'll include that they might need an assistive device. They have a high correlation with low Burke Balance Scale scores, which we'll see. And we don't think they should be walking in the community because they're too slow. And they went on to say they could do it in less than 20 seconds. Now this is interesting because I know there's a slight difference between line 1 and the last line here. They could do it in less than 20 seconds. They are probably independent in activities of daily living. They could probably walk in the community and they'd have a higher Burke Balance score. But there is a difference between the 14 seconds and the 20. Yes, I know. This is what's out there in the literature. Be careful what you're reading. So we just mentioned the Burke Balance Scale. What is that? This is the test most common used by physically therapists to document balance exam results. So later when I ask you, what's the most common test used by physical therapists to document balance exam results? You're going to say what? The Burke Balance Test. So I've given you an overview of the Burke, and I've showed you the 14 components in the next slides. I'm not going to bore you reading the slides, but you could do them on your own. Go to Rehab Measures and download the actual test so you have the form and you can check it off as you work with the patient. Easy equipment to use. Okay. Number 1, please stand up. Don't use your hands. Easy enough to do. You watch them stand. 4 points if they could stand independently. 3 points if they use their hands. 2 points, well, they had to use their hands and it took them a few tries. Okay, 1 point if they needed a little bit of assistance to stand or stabilize, maybe you gave them a little cueing, a little help. 0 points, they needed moderate or maximal assistance to stand. If they're getting 0 points on number 1 of the Burke, you're probably going to stop the Burke right there and go on to another test like maybe the fist, because you're probably not going to be able to do the rest of the test. Standing unsupported. Again, not going to read all these. You could do these on your own. Sitting with the back unsupported but feet supported on a stool. Can they sit there for 2 minutes? Standing to sitting. Okay, they're already standing. What happens when they sit down? They use their hands or not? They lean the back of the legs on the chair or not? These kind of things. Transfers. You have 2 chairs right next to each other, like an L shape. One with armrests, interestingly, one without. Okay, can you transfer from one chair to another? Look to see their level of safety, the use of their hands, cueing, supervision, etc. Standing unsupported with the eyes closed. Standing still, close your eyes, stand still for 10 seconds. Now, patients get nervous with some of this stuff. They think they're going to fall, so you better be right there and you let them know. I'm here guarding you. If you feel like you're going down, I'm going to be here to support you and protect you. And you have them standing right in front of the chair, not touching the chair, but close enough where if they went down, they land in a seat. So you say, how long can they stand safely, etc. Standing unsupported with the feet together. And still, to this day, although I've done a zillion Burke balance scales on a ton of patients, I still have the form with me and I go through each item. Because you don't memorize all these things like that. Go through each item as you do it. Stand unsupported with the feet together. Okay, how about reaching forward? What's this? The functional reach test. Reaching forward with your outstretched arm. It's just a functional reach test. So if you've already done that with a patient, use that for the Burke Balance Scale. Don't feel like you have to do it again. We need to save time. Pick up an object from the floor. So what's the most common thing? People wear shoes or slippers. Put the slipper in front of them. See if they can pick it up safely. Easy. Something light and easy, not a 5-pound weight. Turn and look behind you, over each shoulder. Again, they're standing. Okay, mark the lowest category that applies. Here's what I like about the Burke. Mark the lowest category that applies. Okay, turn around in a full circle. Again, they're standing doing this. How are they doing it? With safety or not? Stool touch. There's a stool in front of them. I want you to stand, touch your foot each on the stool, alternating right, left, until each foot has touched the stool 4 times for a total of 8 times. Okay, going to point 13 of the Burke Balance Scale. Again, go through this with your own form as you do this with a patient. So standing unsupported, 1 foot in front. In other words, the sharpened Romberg. And grading. Can they have their feet in tandem and hold it for 30 seconds? Which foot? Able to take a small step independently. In other words, some people can't do a tandem Romberg with one heel directly in front of the other toe, but it's more like they take a step with 1 foot in front. Different point scoring. They might need help to step, but they can hold it for 15 seconds. Different point scoring. So look through each one. Practice this with a fellow clinician before doing it with a patient if this is new to you. Standing on one leg, the unilateral stance test. Okay? As long as you can without holding on to an external support. Now, in this test, you notice they didn't say the arms are folded, but all the therapists I know and anywhere I've seen in the literature, arms folded across the chest. Now, interpreting this Burke Balance Scale, or BBS. What's the minimal detectable change if a significant change has really occurred or not? That's the MDC. Well, interesting, they've broken it down to if their initial Burke Balance score on the first day of treatment was between a 0 and 24, the minimal detectable change is 5. If it was 25 to 34, the minimal detectable change is 7, and so on. So you can download this at rehabmeasures.org. What is the specificity that predicts that one will fall? 90% for the Burke. That's huge. Sensitivity, 64% predicts people who fall. Okay, so 90% specificity predicts who won't fall. 64% sensitivity predicts people who will fall. People must have a score of at least 45 out of 56 for independent ambulation in safety. That's your cutoffs. With a lot of these tools, we're looking for what's the cutoff? You're trying to convince insurance company a person needs services. That's your cutoff. If they don't get at least a 45 out of a total of 56, they're not likely to be independent ambulators in the community. We like the Burke because it's cheap, doesn't need a lot of equipment, but if somebody is a higher functioning patient, this is not a great test. Okay, that's what we call a ceiling effect. Maybe a patient starts from a lower level of functioning, Burke's good to use. But if they're a higher level, it's pretty basic stuff. Did we ask anyone to walk during the Burke test? No. So you're talking a lower level of functioning. No gait items are on the test, so it is absolutely not a gait test, but it is the most common functional exam used post-stroke. So it's one you definitely should know. So low Burke score predicts falls. Shumway, Cook, and Willicott. Lots of studies done over the years by these researchers. As the Burke scores declined, risk of falls increased. And it gives you percent. The high Burke score, 56 to 54, even with a normal score, there's a risk of falling of 3 to 4%. Okay, so normal people have a risk of falling of 3 to 4%. If the score is below 36, here's an important cutoff. If you're trying to argue to get services for your patient, their Burke is less than a 36. There's a 100% chance that they have an increased risk of falling. 100% chance. Use that when you're arguing with the insurance company. Here's some stats for the Burke for adults in the community, ages 60s, 70s, and 80s. Okay, and it shows you the mean scores also across men and women. Minimal detectable change, again, Donahue study, different Burke initial scores, okay, different minimal detectable changes. Romero came along later and said, well, for the overall Burke, the minimal detectable change is 6.5. So easier than looking at all the different ranges they started. Now, a little Empire State Building, or I'm coming here from New York. How about the Tinetti? This is a favorite because now we're adding not only items from the Burke may be included here, but you're adding gait. So we're testing 7 gait items for 12 points and 9 balance tests for 16 points. The score on the Tinetti is from 0, reflecting the greatest impairment, to 2, independent. So Tinetti assessment tool. Please be aware that this is created by Dr. Mary Tinetti. In some references, it's referred to as the Tinetti POMA, or just POMA, Performance Oriented Mobility Assessment. So it could be the Tinetti or the POMA. You're looking at them walking at a normal and a rapid speed, and we're rating from 0 to 1. How do they initiate their gait? What's about the symmetry and continuity of the steps? Do they deviate from a straight path or go, straight? Is their trunk swaying? Are they flexed? What is the space like between their feet when they're walking? So a lot of different things. I've given you the Tinetti slides here, modified for a lab. Again, you can put this on pause if you're practicing with a fellow clinician and you want to go through each of these, feel free to put it on pause. So sitting balance, getting up out of a chair, some of the same things from the Burke. Do they take more than one try to get up? And how about your patient with the Parkinson's? You might take 8 tries before they could initiate getting up out of a chair. So there's going to be a different score. When they're first up, what's the balance like? Steady, unsteady, what's their base of support? So a little bit more specific here. Sternal nudge, we nudge them in standing. Can they catch themselves or not? Stand with their eyes closed, turn in a circle. Same thing we had before. What if they transfer standing to sitting? Do they have to reach with their hands or are they independent? How about initiating gait? Is there hesitancy? Does it take them a few tries or no hesitancy? What is their step length and height? Does one foot pass another? The right foot swings past the left, etc. So you're going to be going through each of these tests with the patient and scoring. Does the foot clear the floor or do they drag the foot? Do they have foot drop? Some people shuffle. How about their step length? Is it even or not? Are they continuous or discontinuous? So this is a little bit more about the quality of the gait as well. They're ambulating a 10-foot path, so make 10 foot and see, do they deviate from a straight path or not? Do they use a gait aid? Okay, do they sway? Do they spread their arms or flex their knees or trunk? Okay, can they walk without using any gait aid? Okay, and then walking heels are looking at the space between their feet, so their base of support. Heels apart, normal base of support, or heels almost touching. Okay, so how far apart? That's a problem of this test. They don't tell you how many inches the heels should be apart. But typical base of support, the feet are anywhere from 2 to 4 inches apart. So Tinetti score does predict falls risk. It's very well documented for this. Normal Tinetti score 28. Low, high, and very high risk are listed down here for you. And of course, you could download this at Rehab Measures. Another test, gait assessment rating score. Just giving you the name here and a little bit of background about the test. This is looking at the qualitative and quantitative aspects of gait. More involved, takes a lot of time to do, so we're just throwing it out there. If you're interested in using a more precise test for more qualitative values, look at the GARS. Gives you some of the swing ratio, heel to toe, what's happening at the shoulder, hip, and knee. What's happening with the arm swing, the head alignment, other things that the other exam tools don't include. Dynamic Gait Index. This is very popular. I see this used across the board in clinics. So this is looking at changes in gait along with doing a task performance. Well, what's the difference between walking across the room or walking across the room carrying something or doing something else? It's scoring impairments, again, 0 to 3 points per task. And we like the Dynamic Gait Index because it predicts falls likelihood increases 2.5 times for scores under 19 points. So there's your cutoff. If they're scoring under 19, they're 2.5 times more likely to fall. Great stuff for arguing with your insurance companies. Romero reported the minimal detectable change for adults, rounded off 3 points. I don't know where he gets it, 2.9, 3 points. So I've given you the Dynamic Gait Index here. 0 points, of course, for severe impairment, 1 for moderate, 2 for mild, 3 is normal. And we look at them walking level surface speed changes, horizontal head rotation, etc. You can access the tool. What do you need? You need a 20-foot walkway. Ah, there's a problem. You're in home care, and the longest room they have is 12 foot. So you can't do an exact normative referenced DGI. Well, you might have them turn around and do it. Make a note. If you change how you do the test, it is no longer the normative test. You need to make a note. Test performed in patient's home, space limited to 10-foot walking path. Just make a note. You have to have a shoe box. I often use a tissue box, 2 cones or 2 tissue boxes. Things you have right there in the home are easy to use if you don't want to carry around, construction type cones. And of course you need stairs. Some therapist was telling me, I'm in a nursing home, we actually have absolutely no stairs, so I can't do stair training with the patient. Well, what good is that? The patient's in the nursing home temporarily, they're going to be discharged to home where they have 8 steps. and you could never do ambulation training. You know, maybe they need to buy themselves one of those little staircases that we see in the therapy offices. So here's our cutoffs. Less than or equal to 19 out of a total of 24 points predicts falls in elders. This is how you show that someone needs services. Score of greater than 22 out of 24 probably can walk safely in the community. Again, these are from the statistics. Marchetti did some studies on 3 trials of the dynamic gait index. What did they find? They demonstrated differences between involved groups, neurologically involved groups with balance or vestibular disorders, and control groups. Fair to excellent reliability. And a lot of these studies you see, I'm going to just blow through them. You could read them at your leisure, but realize we're looking to show you what's valid, what's reliable, what are good clinical tests to use, what tools stand up to scrutiny. So Whitney, lots of studies done by Whitney, and they said that dynamic gait index and the Burke balance scale, 2 tests we just looked at, agreed 63% of the time. Correlation 0.71. Pretty good. Cutoff point again for the dynamic gait index, 19. What's the minimally clinically important difference? 1.9 for community dwelling elders. And you'll see most of these studies were tested for community dwelling elders. That's like the population they're looking at. Minimal detectable change in those elders, 2.9. What about people with multiple sclerosis? 4.19 to 5.54. What about people with stroke? So you see this at rehab measures that they've taken different populations and tested each individual tool. Normative values for the dynamic gait index across the various decades. Little relaxation for you, little touch of Long Island. Okay, here's one of my favorites, the best test. Faye Horrock, a professor, decided that, okay, her test is the best of all, so we're going to call it the best test. It's actually the Balance Evaluation Systems Test, best test, and this was designed by this professor to evaluate 6 balance systems. She said, well, what are the main components of balance? And we're going to have 108 total scores for perfect score. It's looking at everything from biomechanical constraints, stability limits, reactive postural responses, sensory orientation, think eyes open, eyes closed, firm surfaces, yielding surfaces. Transitions, okay, they're going to change their position. Looking at gait stability, and now they added something different, a cognitive effect. Can you do the activity while thinking about something else? Like, can you walk and chew gum at the same time kind of thing? Okay, again, this is copyright protected. I couldn't give you the tool, but go to this website and you can download your tools from Dr. Horrock for free. Fullbesttest.pdf, which is the big, long, lengthy one that hardly anybody uses because it takes too long. And Faye got a grip on that and said, okay, we made a mini best test. We took some components out to see, does it still work? Got the mini best test. So what are the tools you need? Basic things, stopwatch, one of those foam blocks, kind of like the Airax mats, Tempur-Pedic foam, incline ramp, 10-degree incline ramp. You don't have something fancy, get a 2x4 with a board at a 10-degree incline. This is not expensive to do. 6-inch stair step, 5-pound dumbbell, masking tape, armchair. Okay, easy. You need a 10-foot space for them to do this. There we go, little Verrazano bridge action, door gate to New York City. Okay, 14 components. The mini best. We're going right to the mini best because we don't have time to do all the best tests. If you want to take time doing a lot of different tests, go ahead and download the full best test. But here we're going to see, can they go sit to stand with their arms crossed? Can they rise on their toes with their feet apart? So go up on your toes with your hands on your hips. Can you be on your toes for 3 seconds? Well, you got to be looking at ankle mobility. Got to be looking at ankle strength. Can they stand on one leg with their hands on the hips? So some of these are things we've already tested with the Burke or the DGI. Now we're looking at reactive postural control, not tested on Burke or DGI. Compensatory stepping forward. Patient standing. Examiner's hands are on the front of their shoulders. Tell the patient, just lean on my hands. At some point, I'm going to let go and see if you could balance. And without telling them when, you let go, and the patient's like, whoa. Do they do a step to correct themselves forward or not? Do they lean on you? Do you have to catch them? That's compensatory stepping forward. Same thing backward. They lean on the examiner's hands. Hands are on their scapulae. I'm just going to hold you up, lean on me. You let go all of a sudden. Where does the patient go? How many steps do they take? Different points for different reactions. And then compensatory stepping lateral. You have your hands on their shoulder. They lean. You let go. What happens? How many lateral steps do they take? Do they lose control? Sensory orientation. Standing with their feet together, eyes open on a firm surface like a tile or wood floor. How about feet together, eyes closed on a foam, a moving surface? Incline. Stand facing up the ramp, feet apart, eyes closed. Okay? Do they fall? Do they start leaning into the ramp? What happens? So you're looking at a lot of different things here that weren't considered before. Changes in gait speed. Okay, that's been on there. As you're walking, they walk a 10-foot path. You yell, walk faster. Okay, now walk slower and see what happens as they change speed. Some people flat out fall over. Here's the key. On all of these tests, where are you? Or where's your assistant? Are you guarding the patient or did they already hit the dirt? That's something I see is the biggest error in the clinic. And I was a PT professor for 10 years. We go out to all different clinics, look at how the students are doing in their affiliations. So many people standing there with the clipboard and the test writing and the patients walking off by themselves. Unguarded. Extremely dangerous. Very poor risk management. So you need to be there guarding the patient 100% of the time that you're doing this test with them. So if you have an aide, you have a secretary that can mark a score down for you, make sure. Sometimes I just will work alone. I'll put the scorecard down, functional outcome measure down, walk with the patient, look to see what their performance is, have them sit down, come back, and make my note. So safety is the number one key, and that's what I see missed a good percentage of the time. So if I'm going to ask them to walk with a horizontal head turn, what is a horizontal head turn? Go walk. They're in a 10-foot path walk. Look to the right. Look straight. Keep walking. Look to the left. Keep walking. Look straight. That's a horizontal head turn. They turn and keep their head facing one direction or another until you give the command to change. Okay, how about walk with pivot turns? I want you to start walking. Okay, turn around and stop. Feet together. What do? Some people lose their balance and fall over when they try to stop. They're still going with the momentum. So someone needs to guard them. Stepping over an obstacle. They have a 9-inch box, 10 feet away. Can they step over it without falling over, reaching, needing assistance? And of course, the timed up and go, the tug, is back. Get up from the chair, walk to the wall, turn around, come back. So you measure that. How many seconds? Oh, it took them 12 seconds. Okay, this time I want you to get up, walk to the wall, turn around, come back. But I want you to hold this cup of water as you're doing that. That's a different test. So that's a dual task. What they do in some studies or some tools, they'll say, I want you to do the tug test, but I want you to count backwards from 100 by threes. Now, I'm terrible at math, I'll tell you right out. So if I'm just counting backwards from 100 by threes, I'm going to screw up just about anything else I'm doing because I know I'm going to miss something. So I don't recommend the math task. Do a functional task. Carry the plate to the wall, turn around, come back. But of course, not a hot cup of coffee, not something they could break, something functional. Okay, so mini best test. This should be scored out of 28 points to include the 14 items. She gave a couple of little extra things that if they're doing the single leg stance or compensatory lateral stepping and you're wondering, oh, well, left or right, which way do I score? She did better on the right than the left. Score the worst score. Why? You're trying to prove they need services. You're trying to prove what's their worst that they could be. What's the risk of falling? So don't score the best score, score the worst. I like how Faye just put this together. And then, of course, the tug test. If it took them more than 10% more time, the dual task of carrying something for the tug versus just doing the tug, okay, again, you have to decrease by a point. So go to her website and it shows you very distinctly how to perform these tests. So giving you the scores, I'm just going to blow through these. It gives you each of these things that we just went over. So you have the test here, download it so you have an easy copy to use, and make sure that you score as you go. Okay, but we're in a hurry, right? How long did it take you to do that? Did any of you actually practice it with another clinician? Okay, well, welcome back if you did. If not, I'm a New Yorker, I'm in a hurry. We got places to go, people to see. We don't have time to be doing all these tests. We got managed care, we got to go, right? So what are we doing? People came up and said, okay, Paget and his group said, hey, that mini best test took too long, so we're going to call a brief best test. We're going to choose what we think are the 8 best items from the mini best test and make a brief test out of it. And some of these are actually from the full best test. So hip abduction, they look at the ability for someone to balance with their hip abducted. Functional reach forward, single leg stance, they do each side. Compensatory stepping, lateral push and release. Standing with the eyes closed on foam, which is going to be the hardest of all, and the tug. And they said, well, how do you decide? Can I get away with doing a mini best test or brief best test, or do I have to do the full best test? Well, they rated people with and without neurological diagnoses and said, hey, The accuracy to identify people with or without a neurological diagnosis. 78% for the best test, the full one. 72% for the mini or the brief. So hey, 6 points difference, I'm doing the quick test. And the specificity to identify non-fallers in all three was 95 to 100%. That's huge. So why would you bother spending the time? Okay. Also accurate to identify repeat fallers with Parkinson's. So they took a group of patients with Parkinson's disease and said, hey, correlation between the brief and the mini, 0.94. And with the best test, 0.95. These are great marks. So what are you going to use? I'm going to use the shortest test I can to get the same result. Sensitivity in predicting falls, 0.76. Specificity, 0.84. Still good scores. Similar to the Burke. Mini best test, okay. Test retest reliability, excellent, 0.96. Burke balance scale, okay. Test retest reliability, 0.92. And the minimal detectable changes. So you have these here. So if I'm deciding, oh, do I do the Burke or do I do the mini best test? Well, if a patient's a higher functioning patient, you bet I'm choosing the mini. Okay, it has a lower ceiling effect and it's more accurate to show an improvement in balance. You want to show you made a change in the patient, you're using the mini. Okay, mini best test works for people with stroke. Look at these correlation coefficients for reliability, 0.96, 0.97. What's the minimal detectable change if your patient had a stroke? 3 points. So you saw them this visit, you evaluated them again on day 14. They did 4 points better on the test. Well, you showed a minimal detectable change. You showed progress. So if someone's arguing with you on insurance and they're denying your payment, this is your ammunition. So use a brief best test to save time. Okay, so a couple other studies on normative values for balance tests. Isles, again, did lots of studies on balance and publication. And she looked at the tug, the functional reach, the lateral reach, step test. And they said, you know, there's a significant effect for each test that shows a decline in balance over time. No surprise to us, and high correlation coefficients for reliability. You could test these again and again, and you're going to get the same thing. So she's giving you some wonderful balance test means here. I put them together in a chart. Age range 20s to 80. Functional reach, lateral reach, tug, and step test. So a lot of reliability between these tests. Steffens looked at 4 tests in people from their 60s to 89. 6-minute walk test, Burke, tug, and comfortable and rapid gait speeds. All have high test-retest reliability. Okay, and this shows you some of the values there. 0.95 to 0.97, excellent reliability. Here are some balance test means for across the ages. Males or females in their 6th decade through their 8th decade. 6-minute walk test. How many meters could they walk in 6 minutes? First column, Burke balance scale and the timed up and go. This is a different test. I don't see it used that much in the elderly, called the 4-square step test, but just throwing it in because it's quick, it's easy. All you need is what they say is 4 canes and a stopwatch. I don't use canes, I use tape on the floor. What do? You can make 4 squares. Remember when you used to play hopscotch and you made squares? Or easier, make a plus sign across on the floor so that you have 4 boxes. Patient starts in the box to the top left. So if you made a clock, 12, 3, 6, 9, at the tip of each of your pieces of tape on the floor, they're going to go from 10 o'clock to 2 o'clock to 4 o'clock to 8 o'clock. So they're going to start in box 1, step sideways to box 2, step backwards to box 3, step sideways in the other direction, and then finally to the first box again, forward. So you're having them step forward, backward, and sideways in each direction. And you're going to see how much time did it take them to do that. That's the 4-square step test. So I've given you a little schematic. If you start with the single arrow in box 1, step sideways to the right, now you're in box 2, step backwards into box 3, step with your left foot into box 4, and step with your foot forward into box number 1 again. Then you're going to go in reverse, in other words, counterclockwise. You're in box number 1, you're going to step backwards into box 4, step to the right into box 3, step forward into box 2, and finally step to the left into box 1. So all the different directions they step. There are normative values for all of these. So Lynn looked at responsiveness, validity, and reliability in a whole bunch of tests, and they decided 1080 was the best performance measure, followed very closely by the timed up and go. But all of these tests had very high reliability. So we know that what we're doing works. How about for dementia patients? That's it. Some people have trouble following directions. Could the tests be used? Yes. Blankenford showed excellent reliability of 6 performance tests. The 6-minute walk test, how far can they walk in 6 minutes? Figure of 8, which is make a figure of 8 walking and time it. The timed up and go, the chair rise, like 5 times sit to stand test. And hand grip. And they checked this in people with dementia from 70 to 92. Very high reliabilities across the way. So great, you could use it. Little Brooklyn Bridge action for you. Okay, so now we looked at some of the balance tools. There are certainly many more, but those are quick and easy, down and dirty. What's great about it? You don't need to spend money to have fancy equipment to use those balance tools. They could be used in a SNF, they could be used in home care, they could be used in your private practice clinic, they could be used in the hospital. They're very versatile and they're proven to be valid and reliable. And we have them also tested across numerous types of patient populations so that you can compare. Absolutely marvelous. So what do we do to prevent falls? Now, I'm not here to teach you the interventions because you probably know them already, but I've listed a whole variety of interventions and more importantly, showed you what's out there in the research that said what interventions actually work. What do we do in balance rehab? We have to, of course, identify. We just did our functional outcome measures, so identify deficits, treat modifiable deficits, identify and compensate for fixed deficits. Patients in amputee, give them a prosthetic leg. We made a compensation. Okay? Patient has no knee left, they got a total knee replacement. Okay? What are we compensating for? We just do the best we can to maximize their independence and quality of life. Now again, this is not a vestibular course, but just some activities you'll see used to help people reduce dizziness when changing position and tendency to fall. I'll have them sit and move their head, because moving the head is what makes them dizzy. So tell them, move your head in that direction that normally annoys you, okay, until you start to feel dizzy. Now these are designed to bring them to the brink of their symptoms, but not to exacerbate them so much that it's making them feel like they're going to throw up. Okay, so have the bucket ready, because sometimes people get sick doing these. So sit, move your head until the onset of dizziness. Maybe not as fast as usually aggravates, and maybe slower, just to get used to it. Let the body accommodate. Those rocking chairs come in handy for people with vestibular disorders. Gets them used to the movement. The nervous system accommodates. Have them practice sitting, turning their head left and right. Walking, turning their head left and right. Walking, reaching their head up and down. All different things. So, of course, with supervision and guarding. Now, to reduce falls, just some simple education. When you feel you're losing your balance, start crouching to the floor. Don't just go flying. So if you start teaching them like they do in martial arts, how to fall, they get used to that. Lower their center of gravity so there's less chance of damage. Visualize having good balance. So the brain is still the central processing. It's in charge. Maybe it's slower than it used to be, but the visualization can help. Of course, we talked about footwear. We talked about the environment. What if they're already going like, oh, I'm getting dizzy? Focus on a still object in the distance to keep you going straight. Because if you're looking all around, your sensory system is getting a lot of different input, but focusing on one thing. Even dancers doing spins. Every time they go through a spin, they stop and focus on the same object so they come back. And that helps to reduce the sense of dizziness. Okay, some balance exercise. These are basic things. Typically, I start patients with, lying down supine or relaxed recumbent, lying positions with shoulder shrugs, scapular retraction, because where are their shoulders? They're up and forward, dragging them down. I want them down and back, having them start working that, open up the chest. Neck rotation, quad sets, glute sets, okay, getting those legs stronger. Chin tucks, lying, sitting, standing, getting them out of that forward head posture, better posture balance. Leg lifts in all different directions, hip circles, standing in all different directions. Runner stretches, one foot in front of the other, like the picture. Up and down on the toes, up and down on the heels. Get that ankle strategy working. How about just practicing standing on each leg? Take the activities you actually test with and use them as rehab. If your activities are walking up and down while you're turning your head, then you're going to practice walking up and down while they're turning their head. Practice timed up and go, holding something, holding a bag of groceries. That's the practice. It's the same as the test. Romberg test, standing with one foot in front of the other, tandem Romberg, eyes open, eyes closed. Okay. How about the old DWI, walk that straight line forward and backward? How about walk sideways without looking at your feet? Heel and toe walking. All these are basic. Marching, like you're marching in a parade. Braiding steps, crisscrossing steps one across the other, sideways, moving laterally. Changing gait speed, so have them practice. Walk slow, now walk normal, now walk fast, so they could change those speeds. How about walk, turn, stop, walk, turn, keep going. Or there's something called a star excursion balance test, where they step in different directions. Again, take some tape, make a star on the floor. So make a plus sign, put an X over it, you have a star on the floor. Have them stand in the middle of the star. Touch your toes, 12 o'clock, 1 o'clock, 2 o'clock, 3 o'clock, all around the star. How far can they reach stepping? Or put them in that 4-square box. Practice doing those activities. Balance beams. How many people are still using balance beams in the office? It helps to improve stability. How many of your elderly enjoy jumping and hopping? Well, that may be a bit much for some of them. I actually have a trampoline that I use that has a great big walker attachment for them to hold on to on the top. And it gives them that squishy surface that gives enough to challenge some of their posture. And I have them doing a little bit of bouncing on there, a little bit of stepping in different directions and up and down on their toes. So you work on a stable surface like a floor, work on a moving surface like a foam block or trampoline. Always, of course, with appropriate supervision. How about walking on different surfaces? Carpets, thick carpets, tile, wood floors. How about taking them outside and letting them walk on the grass or the dirt? Very different quality. Do you have a sandbox in your clinic? Think of how great that would be for practicing ambulation. A moving surface picks up a lot of ankle and foot muscle activity. Excellent training. So walking on a variety of surfaces. Where all those fun toys you have, your rocker boards, your Bosu balls, your noodles, all different things. You can get a noodle in the dollar store for 99 cents. You could slice that pool noodle in half. They could use that as a surface to practice some of their balance on. There's so much you could do without spending a lot of dollars. How about those big physio ball programs? Having people work with the balance ball. Lots of fun. So people love toys. People like to have things to play with. Functional activities. I want to have things put away in my office and I want to train somebody in balance at the same time, so I get that grocery bag full of stuff. Okay, the paper goes on that shelf, the cups go on that shelf, the tissue goes on that shelf, and they have to bend and reach and do things in different directions. Maintaining balance. Needless to say, I'm supervising them and guiding them. I could see, oh, she's got some weakness reaching up to the left side. Well, she had that stroke last year. She's having trouble transferring her weight. Okay, let's practice just putting stuff away, reaching up with that left upper extremity. Okay, reaching different directions. Just getting up and down out of a chair. Patients look at me like I'm nuts. That's my home program. Yes, I want you to get up and down out of your chair as many times as you can, and when you get tired, stop. So say they do that 13 times and they're tired. Okay, I want you to do 3 sets of 13 up and down out of that chair. Every day, twice a day, till I see you again on Friday. And then maybe it'll be more next week. So that's therapy? Yes, that's therapy. We're going to strengthen your glutes and your hamstrings, your quads, so you can get up and down out of a chair, or a toilet, or a low couch. This is an exercise. How about practicing actually getting up and down off the floor? Now, needless to say, some folks have a lot of arthritic problems or issues where they can't bend that much. Maybe they could get down with one leg. Maybe they could get down to a low stool and up, but let them practice. Work with them. The obvious curbs, ramps, stairs, inclines, all of that. It's good practice. Walk while carrying stuff around. Something plain like a tissue box. If it falls, no big deal, doesn't weigh anything. How about asking them to carry a 5-pound weight? Well, if they drop that on their toe, that's going to be a problem. You have to explain to your malpractice company. But you have to think about these things. So choose what you feel is appropriate and safe for a person to do. Obviously, not hot objects. What if this person's being discharged at home? They're going to cook. They're going to pick up that huge spaghetti pot and then trip and fall and drop scalding water. You have to think about what they're doing and warn them, you can't lift spaghetti pots. Oh, but I love to cook. My family's coming over. Okay, then you have to get some help. So safety first. Obstacles, stepping over obstacles. The grandkids are coming over. Oh, I have cats. I have a dog. I have to step over these things. So you need to practice obstacles. How about getting them out in the community? How about some fun? Some of my folks love dancing. So they'll go out and they get that adult continuing ed program. They can do some dancing. They love it. And they have someone to hold on to. So they're getting their exercise, they're having a good time, and you know they're going to participate. I have lots of patients love the local Tai Chi classes or Qigong classes. They're like a moving meditation with lots of weight shifting and total body exercise. excellent for balance. How about games? Computer games, the Wii, right? Or there's other kinetic games. Those are very interactive and keeps patients busy. I know many of the nursing homes are using the Wii programs. Wii dancing, Wii sports, all kinds of stuff. Functional activities, how about yoga? How about if they have family to take them out for a little hike locally at the beach or the woods or wherever they are, locally in the gardens. Let them get out and get some exercise. Much better compliance. They're going to do it if they enjoy it. If not, they're not interested. But make sure they have appropriate supervision and guarding for assistance. Let's take a look at Tai Chi for balance training. I'd recommend you can easily look at some Tai Chi movements by Googling it online. You can take a Tai Chi class. But they've shown a randomized clinical trial of 684 people in the community who had some falls risk factors. They said, well, let's give them Tai Chi exercises once or twice a week, or a control, just basic low level like calisthenic kind of exercise. Falls rate reduced 58% in all the groups, but no difference in balance and strength with general exercise versus Tai Chi for this study. But what was different is 65% of the patients in the Tai Chi group continued the activity at the end of the study. The people doing the boring exercise stopped. So what do you want? You want lifelong activity. You don't want them to do exercise, then stop, it's over. No, this is like brushing your teeth every day. It's lifelong. Okay, Tai Chi for people with dementia. This even works for people who have cognitive impairment. Yao did a pre and post test design with 22 people using the caregiver as well as the patient together as a dyad. And they measured the unilateral stance and the tug. They did 16 weeks of what they called a special positive emotion motivated Tai Chi protocol. The unilateral stance test improved from week 4 to 5.1, week 16 to 5.6 seconds. So better unilateral stance, and the timed up and go improved as well. So these are things that you can do for people with dementia, again with the assistance of their caregiver. Systematic review of Tai Chi, 159 trials on balance. It took 1,625 people. And they said it significantly reduced falls risk. So we're seeing this coming up. Very fun stuff to do. So there's a lot of evidence-based outcomes on exercise and balance interventions. We've shown improvements in the research. And I'm just going to show you some slides of evidence-based research, mostly systematic reviews, good clinical trials, randomized clinical trials, showing that these interventions work. So targeted exercise. There's a special exercise program that's copyrighted called the Otago Exercise Program that includes education and visual information, a vestibular kit, and they compared the Otago program to a control. They said, well, after 6 months, the exercise group, the Otago program, had significant improvement in the functional reach, the step test, gait width, and hip abductor strength compared to the control group. What did it consist of? I've listed some of the activities in the Otago program. Again, you could kind of read this on your own or just Google the Otago exercise program online. It includes also a 30-minute walk and about 20 minutes of exercise done over 5 times a week for a period of 6 months. So how about core training? How important is the core? Get those abdominals working. So Geriatric showed for a 10-meter walk test, spinal mobility, the functional reach forward, and the tug test. Exercise group doing progressive core training had significant improvement in their spinal mobility, their gait speed, functional reach test, and the tug. How about for home care? Does it work for home care? Well, Whitney, looking at a huge number of people, talking almost 12,000 patients who had fall risk, who were getting any variety of rehab programs. They looked at the Burke, the Tinetti, which is the performance-oriented measurement assessment, that's the Tinetti, and the DGI, and something we didn't cover called the Modified Clinical Test of Sensory Integration and Balance. Most of that test is subsumed in some of what we covered here. If you are interested in that, certainly look for that more online. Meaningful clinical gains across the board. Okay, it was measured for each. So minimal detectable change for the Burke, they said 12 points. Tinetti, 8 points. Dynamic Gait Index, 7 points. And of course, the CTSIB modified, okay, 1 or 3. How about for folks with a total joint replacement? Here's a total knee replacement. PIVA did a double-blind randomized clinical trial and said, well, let's take people with the typical, let's just give them strength and range of motion stuff, which we call functional training that's classically used for people post-total knee arthroplasty. Okay, the second group, functional training, just like the first, but they included a balance component. So they included agility programs, stability, perturbations, and they saw, you know, if we added a balance component of training, does that change the results in patients who have total knee replacements? So what they measured as their variables: gait speed, the chair rise test, the unilateral stance test, the Womack, Western Ontario McMaster, lower extremity functional scale, and of course adherence, pain, stiffness, and attrition. There's a huge number of variables that they looked at. So what were the functional training? The typical warm-up exercise, strength, endurance, task-oriented exercise, chair stands, walking, bicycling, stairs, and a cool down. Typical total knee rehab. What was the balance activities? They added perturbation and agility. And I've done that for years with my total joint replacement patients because you could see they had balance deficits. Before it was cool to talk about balance deficits. We have to do something about this. These people are falling down. Sidestepping, braiding, tandem walking, crossover steps, shuttle walking. Can you walk with changes direction? Okay. Can you work on a tilt board, a foam mat, roller board? Okay. All these different balance activities. This was done actually as a home program for patients for 4 months, twice a week. What's the difference? Everybody improved. Of course they did. We wouldn't be using these activities if they didn't improve, but there was better improvement in the group that added the balance training, okay, particularly in single leg stance and gait speed. So Gillespie did a systematic review looking at all different fall prevention programs. What was important? And here's one of the answers on the test. Okay, significant reduction in fall rate and risk in what? Multi-component exercise and home programs, including home safety assessment and modification. So does exercise work alone? It helps, but not as good as when you combine it with home programs, home safety, and modification. Okay, more systematic review. Economic savings. Well, give them as a home program, saves more money. They looked here at 8 risk factors in people over the 80 years old. Found they could save money. How about addressing that long laundry list of drugs? Does the patient really need to be on all those medications? Check with their doctor. Can you review their drug list? I noticed that, the rheumatologist gave them this, and the cardiac doctor gave them that, and the primary care gave them that, and one doctor didn't talk to another, and they're taking a bunch of doubles. And nobody knows it until they looked at this med list. That's dangerous. So that's important. Drug discontinuation, especially psychotropic drugs, will reduce those fall rates. Interesting, they said there's no effective cognitive behavioral therapy. Interesting. I've seen 2 ways. They said no effective fall prevention education, although some of the newest statistics show that might be helpful as well. And I've seen both no effective taken vitamin D and a range of different reports on calcium, vitamins, and other things. So research is still out on the vitamins. Physical activity. So Shepins did a meta-analysis, again, high-level clinical study, 20 studies, positive correlation between fall-related efficacy. How confident are they that they could participate in activities without falling? And whether or not they actually do the activities. There's no surprise. So you want people to participate, you have to improve their confidence in their ability to maintain their balance. Another, no surprise, Kadori, systematic review from across many years, 1990 to 2012, so right up to recent studies. What works? Here's the test question. Multi-component exercise programs. Balance training, endurance, strength shows a positive effect on improving gait, strength, balance, and the rate of falls for older, frail adults. So what works? Multi-component programs. Okay, validity of studies, another systematic review, 2000 to 2010. Okay, they turn around and say just the opposite. Oh, few reports describing external validity, so you can't generalize. Here's a problem with the literature. A, you have to know literature enough to be able to research and understand it. And B, there's always one that's going to say something opposite. So just throwing it out there for you. So exercise improves balance and mobility test. Yang looked at people in the community again. 6 months of home exercise, balance, and strengthening versus a control group doing their usual everyday activities. Significant improvements in the treatment group doing the regular exercise. Step test, functional wreath, strength of the hip abductors, space between the feet when they're walking, okay, and I gave you a range of the typical exercises they're doing. Okay, balance and strength improves fall risk. Again, evidence supporting balance and strength training for community-dwelling adults who have a high risk of falls. We know that this works. Clemson looked at something called the LIFE program, and the LIFE program, interesting. They took a group of people, said, let's give them the Lifestyle Integrated Functional Exercise LIFE program, which is basically strength and balance training and also selected activities, but they're done throughout a person's day. It's not just done like twice a week or once a day. It's structured throughout the day. Group 2 had the usual program of balance and leg sessions. So they did 5 sessions of this and 2 boosters followed up by a phone call. How are you doing with your exercise? They actually had a third group that just did some gentle range of motion and got 3 home visits. What did they look at? What was the rate of falls in these people? 3, 6, and 12 months. That's a nice long study. Life intervention group had a 31% significant reduction in fall rate. That's nice because they integrated the balance activities into their day. They had improvement in static balance, function, ankle strength, and participation in everyday activities. So take a look at some of these programs. Do Google the Life program. And I've given you a list of some of the exercises there included. Okay, weight shifting, narrowing the base of support. How would I use this? Oh, patient says, well, I'm going to be at my kitchen sink. I'm going to do the dishes. Good. Instead of doing the dishes with your feet way apart like that, move your feet a little closer together. Oh, while you're watching the television commercials, I want you to stand with your feet together instead of standing with your feet apart or sitting in your recliner chair. Okay, moving to their sway limits, actually practicing, turning, changing direction. A lot of the things we looked at right here in this program. Tandem standing, standing on the toes. Okay, stand for a while on your heels, stand for a while on your toes. What else do I tell patients to do? I want you to practice walking across your living room just on your heels. I want you to practice walking across your bedroom just on your toes. So they're putting this in with their day. They're walking across the room anyway. They might as well do something functional that builds up their balance. Stairs, knee bends. You know, once in a while, pick up something from the floor. Oops, I dropped a pen. Pick it up from the floor. Get used to moving that way. So very good stuff. So what works? We know Tai Chi works. It's fun. It's out there in the community. You could get it on DVDs. You could get it on the internet. How about the vision? Think about you're watching someone walk around with their rolling walker and they're looking down. And they're looking. Why are they looking down? A, their posture's probably lousy. B, they're usually wearing bifocals. So if you want to see at a distance and the floor is at a distance, you have to bend your head down to see. If they're looking through the bottom of the glass, that's for reading up close. They can't see the floor through the bottom. So I often recommend get a set of single vision lenses. Not bifocals or trifocals, but single vision so they can see the floor looking straight ahead and still see through the bottom of the lens. Something that simple could help reduce falls. Okay, how about withdrawal of those psychotropic medications, home safety modification, and risk assessment? Plenty of courses about this online. Gillespie, more randomized clinical trials. Exercise is the most common intervention used. Okay? To try to reduce fall rates. What's the answer on the test question? Here we go again. Exercise is the most common intervention used, followed by multifactorial interventions. But what works better? Multifactorial interventions. Remember that. Okay? Those are the ones that reduce fall rates. Okay, there's Our Lady in the Harbor standing tall. Okay, what does the American Geriatric Society say about this? They have a panel on falls prevention. You want long-term balance and exercise training. This is a lifelong maneuver. This is not something you do while you're in therapy or just twice a week for 6 weeks. This is part of your everyday living. Keep yourself in shape. The environment has to be modified, as we discussed. Meds have to be reviewed and modified as needed. What about appropriate assistive devices? Okay, they're in a skilled nursing facility. When do people fall? They get up in the middle of the night. What are they getting up in the middle of the night for? Because they have to go to the bathroom. What is it like in the middle? It's dark. How is their vision? All kinds of reasons why the main time people fall in the skilled nursing facility is in the middle of the night, getting up out of bed. So what do? You change the lighting. Maybe you have motion detector lights. Okay. What about bed alarms? That I hear is the most common thing used. If that alarm rings when they get up out of the bed, so aid knows, get in there and protect them. Now, in the old days, they used restraints. That's considered the big no-no today, but just putting it out there. Some places might still be doing that, but that's considered an ethical issue. How about hip protectors? They're putting those cushions on the hips, so if they do fall, it's somewhat cushioned. That might be helpful too. Educational and behavioral recommendations, visual interventions, make sure they get their eyes checked regularly, patient education, medical management. Look at the various diseases affecting them, look at their footwear, look at the various impairments. Is there something that we can do medically to help? Okay? And of course, restraints we said are no-no, but they are still listed on the American Geriatric Society panel on falls prevention. So what's our conclusion? What works? Exercise and balance programs. Fall risk and incidence are definitely reduced. Multiple factors are improved by exercise and balance interventions. Combine the multifactorial interventions. And we know that our balance assessment tools are valid and reliable, and we know that they work. So there's our balance rock. You too can help your patients to stand more like a rock, maintain better balance, reduce falls, and you are perfectly trained to be able to assess and treat those problems. So share this. I'd highly recommend to, again, download these functional outcome measures from online, get together with a fellow clinician, and practice using some of these tools. Make sure that you don't commit that one fatal error I see so commonly in the clinic in failing to support and guard your patient. Okay, so these should always be done with excellent supervision and guarding to prevent falls right there. Because when's the most likely time they're going to fall? In the middle of your testing, when you're pushing them off balance or asking them to challenge their balance. So you need to be ready. You know, back when I was a physical therapy professor, and we had our beginner classes, some of our students, PTs and PTAs, and we had them come in. We had to teach them how to guard. We had to teach them how to do transfers, how to prevent patients falling. What did I find with my entire class? They did great in class. They're working with each other, doing balance training, and they're guarding each other perfectly in class. And then it comes time for them to do their exam. And they have to show their competency in being able to prevent someone from falling and transfer appropriately, all that good stuff. Well, I'd surprise them on the exam, and all of a sudden they found that, oh, their fellow student was not playing patient for them. I was. And the teaching assistants. So when the professors are playing patient, guess what we do? We fall down. I fell down on every single student in the class. They were mortified, as you can imagine, and every single one of them failed the test. So I was the evil professor. But I taught them a lesson right from the get-go. They're all faking and holding themselves up when they're practicing in class. I taught my students from the beginning. Make believe you're a real patient. When you're playing patient, act like a patient. Because your fellow student's going to go out to the clinic. They're going to be working with somebody in a hospital, a nursing home, home care, wherever they are, and somebody's going to go down on them. And if they didn't practice how to react when somebody actually goes down, they're going to get hurt. They're going to blow their back out. How many students I know got herniated discs, dislocated their shoulders, fell down with the patient and broke something? The stories are out there. So make sure that you are guarding appropriately. And when training someone new, I went down on these people, so they knew, oh yeah, somebody might actually go down. And they knew how to train very differently. So I know there's a lot of safer therapists out there as a result of that kind of training. So keep it in earnest, put the pen and the paper down, be there with the patient. My other recommendation is make sure if you're working with a team in a clinic that everyone performs these assessments the same way. Because you know what happens. One PT sees the patient this visit, PTA might see him the next few visits, and then they're on vacation. Another PT comes in, and they do the test differently. So why do they get a different score? Or how do you explain that a score improved or actually worsened? So if your therapy's helping, the score shouldn't have gotten worse. Well, what's different? Oh, you evaluated the patient at 8 o'clock in the morning when their meds were working. Now it's this person got evaluated at 3:30 in the afternoon. Their meds were down low because they didn't get their next med. And so everything was different. How do you explain it? You have to look at things like that. Or in between the time the patient was evaluated and 4 weeks later when they're reevaluated, well, what happened? Oh, you didn't tell them about that little surgery they had. Well, maybe that's why they went downhill. Maybe that's why the scores changed. So you really have to look at the big picture. Make sure as much as possible, if you can, reevaluate at the same time of day and under the same circumstances so that you're testing normatively. If the testing circumstances are different, which they can't help but be different because it's a different day, but you need to see, you can explain if there's a difference that doesn't make sense. If the patient didn't make progress, you need to explain. If the patient did make progress, well, gee, you need to explain why what you did worked and to show that progress over time. So hopefully you'll be able to do that and show that. The research indicates that we're doing a good job. More research is forthcoming, so keep an eye out. I'd like to also mention that I do a live course where we practice each and every one of these balance tests so that you see how many people are doing things differently. And I travel all over the US, and I've seen this done differently in all different states, even therapists in the same facility who came to my course together. I find they're all complaining about how they did things differently. So normalize, standardize, so that everyone's doing the test the same way, so we can say that it is indeed valid, reliable, and accurate. So I'd like to thank you. My name is Teresa Schmidt. My company is Exercise Resources Incorporated. Do check out my website for fabulous hands-on seminars, as well as home-based web tutorials, group programs. You can even bring a seminar right to your facility if you like one live there for your group. So contact me at edgercise.com. There's a little biography there for your interest in my background. If you want to learn more, I've given you my website there. We have both online as well as live programs, or we could bring a conference right to you as well. There's Sachi, that's my baby. She's got pretty good balance. And you have a reference list at the end. Again, that rehabmeasures.com website is absolutely phenomenal for downloading some of these tools, so do check it out. And again, there's a beautiful Brooklyn Bridge and a nice view of downtown Manhattan. Thank you very much, and enjoy the work. God bless.